for this invitation and this opportunity to talk about COVID-19 and what we're doing in Louisiana, and happy to share some thoughts about, where I see this going over the next months and years, nationally as well as in Louisiana. And of course, let's answer any questions you have about the work that we're doing. I'd like to start always by just clarifying a few things about where we are. So in January of 2020, I returned back to the country from Taiwan. And the next day, the first case of COVID-19 was diagnosed in the United States. And my life has changed ever since that moment. It's been pretty much COVID-19 all day, every day, until the uprising resulting from recent cases of police brutality that have been videotaped. And pretty much these two pandemics, both the viral pandemic, but also the police brutality pandemic, have pretty much taken over my life. But as we talk about this novel coronavirus, a lot of discussion involves terminology that I just wanted to clarify, because we hear terms used and we hear the terms used interchangeably, and I just wanted to clarify what is what. So the coronavirus is a family of viruses. There are many viruses in the family of coronaviruses. In fact, the rhinovirus that is one of the main causes of the common cold is a coronavirus. So to simply say the coronavirus is not exactly accurate. It's just describing a family, not the individual virus. Now, the virus that that's causing this pandemic currently is a virus called SARS-CoV-2. SARS is severe acute respiratory syndrome, which is the SARS part of it. CoV, which is an abbreviation for coronavirus, meaning it's part of the coronavirus family, and 2, meaning it is the second SARS virus in the coronavirus family, and therefore the second outbreak that we've had of this type of virus, which is a virus that jumped species in China, believed to be from bats or minks, and jumped species into humans in China. COVID-19 refers to the disease that results from being infected by the SARS-CoV-2 virus. So COVID-19 meaning coronavirus disease, 19 is the year 2019, the year that the virus was first discovered in China. So this chart shows what's been happening internationally. I have picked a few select countries here just to give you a sense of how the outbreak has played out around the world. As you can see, the United States has had the worst outbreak in the world. Brazil is rapidly catching the United States, and now actually has an average daily rate of confirmed cases that exceeds the United States. So they are on a really bad trajectory, and over time they will likely surpass the United States as the country with the largest outbreak. This is total numbers. Now, of course, there are differences in the size of countries. So the real comparison needs to be a per capita comparison, and here it is showing number of cases per million, which allows you to compare more equally across countries. But no matter which way you show it, it shows that the United States has had the worst outbreak to this point, and Brazil has caught the United States, and Mexico is coming up closely as well. So the idea that this virus is going to dissipate in the summer seems at this point unlikely to be the case, and in fact seems to be increasing in its prevalence, including in many states in the United States where it is increasing in prevalence. This is just showing the number of deaths from this virus across the entire world. So you can see the earliest deaths occurred back in January. And in just this short period of time, we've had a substantial number of deaths in the United States. COVID-19 has been the leading cause of death in the United States for the last 3 months. In fact, it is literally true to say that it is more serious than a heart attack. COVID-19 kills more people today than heart disease, which is typically the leading cause of death. We're now over 120, approaching 125,000 deaths in the United States. And at the current trajectory that we're on, we will exceed a 250,000 deaths in the United States probably before October 1st. Early on, most of the data that came out around COVID-19 and who is suffering from it didn't include data on race. Louisiana was one of the earliest states to put out data. That early data showed that 70% deaths were African American, while African American comprised about 32% of the population of Louisiana. As the data has become more clear, we've collected more data. The number is closer to 58 to 59%. So it looks, so the disparity in death is dramatic, but not as dramatic as originally reported with the earliest reports. So we're at roughly 59% of the deaths in Louisiana being African American, while 32% of the population of the state is African American. As a result of those early data and the finding that African Americans were disproportionately impacted, the Louisiana governor appointed a task force and asked me to co-chair that task force, which I have agreed to do. The Louisiana COVID-19 Health Equity Task Force is tasked with providing recommendations to the governor and to other state officials on how we can minimize the disproportionate impact of COVID-19 on African Americans and other people of color. The goal of the task force is to provide reliable and data-driven information on COVID-19 safety and prevention, provide the medical community with best practices and protocols for treating communities with underlying medical conditions and health disparities, and ensuring that testing is available to all communities. We've organized that work around a set of key areas that we think are important to address as they affect people of color, such as testing and contact tracing, developing communications messages that are culturally tailored to the various ethnic and racial groups that we need to reach out to, improving the quality of the data that's being collected and the data analysis that's being done so that we can fully understand the nature of this disease and where it's going, how it's spreading, to create a dashboard so that people can keep track of how we're doing in terms of health equity in COVID-19. We also have an emphasis on prison populations and nursing homes. Louisiana is widely regarded as the incarceration capital of the world. The United States has the highest number of people incarcerated of any country in the world, and Louisiana has the highest number of people incarcerated of any state in the United States, which is where that moniker of incarceration capital comes from. We've also been focusing on the nursing home population because, as you know, almost 40% of all deaths across the country from COVID-19 have been among people living in nursing homes. And also looking at policies and regulations and look at the regulatory environment to look at how the laws of the state might be impeding efforts to address COVID-19. Community outreach and, of course, racial disparities is in healthcare is ultimately what this is all about, because what we want to do, we're in abnormal times now, but what we don't want to do is to go back to normal, because normal for Louisiana was one of the least healthy states in the country with dramatic disparities by race, by geography, and by socioeconomic status. And what we don't want to do is go back to that normal, but rather come out of this pandemic and go into a new normal that is more equitable. But this is just showing kind of where things stand right now with it. You know, we had our worst spike in cases back in early April or March into early April. We have, as the terminology has come into the media, flattened the curve. And we've done that generally. We've reduced the number of new cases, reduced the number of deaths and hospitalizations from COVID-19. However, but we've begun to open up the state again, and I think it's instructive to point out that we are seeing an increase in cases in Louisiana, and if that current trend continues, we may have to go back to another stay-at-home order. Here's the data on deaths, which, as you can see, it pretty much mirrors the cases, but if everything seems to be shifted a little bit to the right, and that's because typically what happens is that the infections occur, they don't get diagnosed until about a week later, and then the deaths usually occur about 2 weeks after that. One of the big concerns of this disease is its impact on healthcare resources. And this is a real concern that I personally have, especially for some of the rural areas where we've put prisons. So the prisons tend to be in rural areas. They were placed there mainly because of employment opportunities to bring employment opportunities to those rural areas. Of course, these prisons are incubators for this disease, and the workers who work in the prison typically live in the communities where the prisons are located, which means there's a great risk of infection in the rural areas, and that's what we are beginning to see. Rural areas tend to not have hospitals with sufficient ICU capacity or ventilator capacity to handle a major outbreak. In some counties, or in Louisiana, as we refer to them as parishes, in some of the parishes, you don't have any hospital at all. And others, you have hospitals with no ICU and no ventilators. And in other rural areas, you may have hospitals with 1 or 2 ventilators. So these are communities that are not prepared to deal with the healthcare resources that New Orleans has or other big cities has, and it's going to be very difficult for those communities to deal with the number of cases that they may start to see as the spread continues. Now, we've talked about race and COVID death, and I put this here just to give you a sense of where things stand across the state and how you might want to think about this. So this is showing the death rates for African Americans and for whites by parish or county. The African Americans are in green, whites are represented in blue, and then I've added this lime green line here called ratio to show you the difference, the black to white ratio. So if that number is less than 1, then that means that the white rate is higher than the black rate. If the number is higher than 1, then that means that the black rate is higher than the white rate. And as you can see, there's actually a fair amount of variation. In most of the parishes, African Americans have a significantly higher rate of death rate compared to whites, but there are some parishes that are in the reverse, where whites have a higher death rate. And of course, if you look across all of these parishes, you see that there's variation in how big the disparity is from one parish to the next. So this suggests that there are conditions on the ground in these communities that vary, and these conditions are playing a role in who's getting infected, who's getting access to healthcare, and ultimately who is dying from this disease. That it is not a simple matter of biological differences or something endemic to being in one race group or the other, but rather there are important social, economic, behavioral conditions across the parishes that are playing a role here, which means that there's something that we can do as humans. There are things that we can do to change the way our communities operate that may have an impact on the disparities. This is very new data that we've just started to collect, and we're just beginning to get wrap our brains around it. We haven't quite gotten into it fully yet, because this is only a day or two old. I think I got this data came out on Friday. This data is showing that we have a relatively small Hispanic population in Louisiana, but that population seems to be having an extremely high rate of infection And there's a new population that we're going to have to begin to attend to and put more resources into addressing. And this is a new challenge for the task force, for the governor's task force, that we're going to be taking up going forward. Now, why is it that African Americans are disproportionately impacted? This is the true answer to that question is that we don't know yet. We simply have not done enough research to be able to tell you what exactly is going on. But when this was first discovered, I recall the Surgeon General making a comment that African Americans are dying at higher rates because of underlying health conditions like hypertension and obesity and diabetes, asthma, COPD, other conditions like that. And his advice was that they need to change health behaviors. That African Americans needed to smoke less, drink less, exercise more. And that would address the COVID mortality difference. That explanation is a convenient explanation that places the onus on the individual and their behavior and absolves government and society in general from responsibility. And in reality, there are disparities between Black and white Americans in obesity and hypertension, asthma, COPD, diabetes, but the disparities in those conditions are not nearly big enough to explain the disparity that we see in COVID-19 deaths. In fact, while it is true that African Americans have a high rate of each of those conditions, and African Americans should smoke less, drink less, and exercise more, it is also the case that white Americans should smoke less, drink less, and exercise more, that Hispanics should smoke less, drink less, and exercise more, that every racial and ethnic group in this country needs to smoke less, drink less, and exercise more. And in fact, whites, especially in the South, have extremely high rates of every one of those conditions that we know increases the risk of mortality if you are infected by COVID-19. The white population of Louisiana is one of the least healthy populations of any group in the United States. And to suggest that these underlying conditions among African Americans is the explanation, but it defies logic. Now, other explanations that have come out: distrust of government and the acceptance of myths, such as the myth that African Americans could not die from COVID-19, which was a fairly popular myth early on. These are probably contributors as well. African Americans do, and I would argue rightfully, have distrust of government institutions and maybe less likely to respond if CDC or other government agencies should suggest that African Americans should behave in a certain way. The data, however, shows that African Americans are more likely to wear masks than whites. African Americans are more likely to engage in physical distancing compared to whites. So actually the health behaviors to control disease that are recommended are actually more common and more prevalent among African Americans. This issue of myths is a real issue. There are campaigns in social media targeting African Americans intentionally with misinformation and designed to stoke distrust. These are issues, and one of the issues that we're going to have to really be concerned about, and I'm very concerned about this, is that when we do get a vaccine for COVID-19, when that does happen, we're going to have to deal with the anti-vaxxer movement and people who are putting out messages suggesting that people should not get vaccines. It's going to be another big problem. But I think that what's happening here and why African Americans and people of color have higher rates of death from COVID-19 are the explanations that are on the right side of the screen. I think it's about occupations. I think it is about government policies, and it is about racial segregation. So what I mean by occupations is if you look at who has a job that allows them to work at home on Zoom and still collect their full salary, this is disproportionately, African Americans are less likely to have jobs like that. When you look at who are the essential workers that keep the society running, who are the people that are the bus drivers for driving mass transit, buses, subways? Who are the people working for Uber Eats that bring your food, your food to you so that you can stay at home and stay safe? These are disproportionately African Americans, which means that there are occupations that put them at greater risk of being exposed to the virus and greater risk of being infected. Government policies have played a role here too. So here in the South, most of the states in the South and many of the states in the North as well are what we call right to work states. So these are states that do not have strong unions and union protections for workers, so that workers are placed at increased risk. For example, people who are working in meatpacking plants and other occupations like that don't have the union protections that are able to help them to not be exposed to the virus. Medicaid expansion is another issue. So the Affordable Care Act expanded Medicaid, allowed for the expansion of Medicaid to many more, millions more Americans. However, most of the states in the South, with the notable exception of Louisiana and Kentucky, the other states in the South have refused to expand Medicaid. And as a result, you have many more people who are uninsured than you otherwise would have had that were uninsured, and therefore unable to access health care. And we know that when people don't have good access to health care, don't have health insurance, they are more likely to delay seeking care when they think they need it because of the financial implications of that. Additionally, many states have had hospital closures. Hospitals have closed down because of their failure to expand Medicaid. And so when people come into the emergency department in need of care, they provide that care, but without the Medicaid program, they're not able to get reimbursed for that. In some hospitals, Georgia is one notable state that lost a good number of hospitals as a result of not expanding Medicaid. And then finally, wages. In most of the states of the South, wages are artificially low because of low minimum wages that are held down by the state legislatures. And as a result, people have less resources, and therefore they're less able to mitigate or have the financial resources to mitigate when something like this occurs. And then finally, segregation is a extremely important feature of American society that is helping to spread this disease within certain ethnic groups. So if you consider a scenario, a very likely scenario for a city like New Orleans, New Orleans is an international city. It gets visitors from all over the world. Mainly people come to the city and they go to the French Quarter and a few other places in the city. And the hospitality industry is the largest industry in the city, and in fact, the largest industry in the state of Louisiana. Many of the workers in hospitality are African American, and it's likely that the earliest transmissions occurred from visitors to the city. African American employees in the hospitality industry interacted with those visitors and contracted the virus. And when those workers, those hospitality workers, go home, they are more likely going home to a racially segregated neighborhood, community, census tract. And as a result, the people that are at risk from infection from them are other racial and ethnic minorities. In the case of New Orleans, it's predominantly African Americans. So when you look at a disease that's spread based on physical proximity, you should expect that racial segregation will lead to the virus spreading first within ethnic groups that live together in segregated areas. And I think this is a more of an explanation for what's happening here and why African Americans are disproportionately impacted than explanations such as pre-existing conditions. And I'm sure you'll have some questions about that. So I wanted to point out a couple of things that we're doing at Tulane. And as Rebecca reminds me, it's Tulane, not Tulane. So you read T-U-L-A-N-E, but it should be T-O-L-A-N-E. Well, actually T-O-O-L-A-N-E. But we, early on in the outbreak, we established a daily newsletter called the Tulane Outbreak Daily. This is a curated compilation of the latest news on COVID-19. If you're interested in getting that daily update and finding out what's happening all over the world with COVID-19, you go to tulaneoutbreakdaily.org. You can put your email address in and you'll get a daily email around, we send it every afternoon. And it's and some of the people around the world who are really working on this issue, a lot of the scientists, policymakers subscribe to this newsletter, but it's available to anyone who wants to be abreast of what's happening with COVID-19. The other thing I wanted to tell you about is the Skin Youre In. This is a health communications campaign that we've established. This communications campaign is targeting African Americans with information, authoritative information around COVID-19, with the intent of counteracting the misinformation that has been targeted to the African American community. If you're interested in the Skin Youre In, the website is TSYI, which is just the initials for the Skin Youre In, tsyi.org, where you can go to the website, learn more about the campaign. And of course, we are on social media, so we have all of the major social media platforms we're active in putting out authoritative information. I hope that you'll join us and follow us on social media and ask others to join as well, because this is a place where you can get accurate information that is specifically targeting African Americans. So I'll stop there and look forward to the dialogue and questions that you have.
Thank you so much, Dr. LaVeist. We really appreciate the information you share coming from the state of Louisiana. And with some of the comments in the chat, it really resonates with the present circumstances here in Pittsburgh and Pennsylvania. I want to jump into questions. And we have a question regarding data, some of the amazing data that you've shared. And this is posed by Mr. Rick Williams. So I will welcome him to unmute himself and ask it directly. It's regarding elderly populations, such as in states in Pennsylvania, which has one of the eldest populations in the country, as well as if there's data that's segregated by, disaggregated rather, by gender as well as race.
Yeah. There is. One of the things I would say, since we have not had a coordinated national or federal government response to the disease, each state has gone its own way, and that's this, the states have taken leadership. And as a result, states are all doing things a little bit differently, which makes it very difficult because we don't have a coordinated national data that we can look at, and we're not all collecting data the same way so that we can really learn from each other. This is one of the, I think, most unfortunate aspects of the federal government's failure to mount a national response. So there are pockets around the country where you will find the data systems are strong enough to look at things like gender, within age, within sex, and within race, like the kind of analysis that the questioner is asking about. Other states are simply not collecting the data in a format that will allow them to do that sort of thing. So it really varies from one place to the next, to the extent to which you can find data and you can do that type of analysis. And even in some states that do collect the data, many states have been hesitant to make the data available outside of the normal reporting through CDC. But what the data that has come out has shown that men appear to be at greater risk of death if they are infected by this virus compared to women.
Thank you. And if Rick is available, you can feel free to unmute yourself and ask your follow-up question.
Hi, can everyone hear me?
Yes.
Okay, good morning. And Dr. LaVeist, that was incredible work, research, and just want to thank you for sharing that with us. In Pittsburgh, we are trying to, well, I'm part of the Gender Equity Commission, and we have a a white paper and recommendations coming out that will be released. I think we might have released it last week. I think it's called Gendering the Pandemic. And we have a list of recommendations that we're asking for the city and others to take heed of. And if I will forward that link to the Forbes Fund for them to share with you with that document. We've had some researchers that have attempted to get that information that you said, and it seems like there's a concern of not releasing it, like you said, of how it's broken down based off of gender, which you just said was powerful. Black men that get the virus are more likely to die than the other races. And that's very powerful, and I think that message probably needs to be shared across the country, not just in this forum with the Forbes Fund. But I also wanted to mention is the follow-up question that I put in the chat. How do you see it in warm states versus states that are cool, so to speak, like our Northeast cities and states here in Pittsburgh and so forth? Is that a difference? Because we're second in the country to Miami-Dade, Florida, in regards to the elderly population in the country. And so, we saw even in Pennsylvania, most of our COVID-19 cases are elderly populations that are secluded in nursing homes and so forth. Are you seeing that in your research as well? Is that a trend going across, being measured and so forth? So can you elaborate on that a little bit more, please? Thank you.
So let me just make sure that I'm understanding the question. You're asking about age. You're asking is there a trend of more deaths among older people? Is that the question?
Yes.
Yeah. Well, we do know that we know that age is one of the characteristics that increases the likelihood of death if you are infected. So we do know that. So the CDC has indicated 65 years or older. Now, one thing the age issue is probably being biased by the fact that very old people are more likely to live in congregate living conditions like nursing homes, and nursing homes are perfect environments to spread this disease, this virus, so that a lot of the deaths that have happened among older people have happened in nursing homes. Approaching 40% of total deaths have happened in nursing homes. And so these are going to be older people. So I don't know that the age factor is as strong as that data would suggest, or if it's that older people are more likely to live in congregate living conditions and therefore much more likely to be exposed. But we do know overall, even among those deaths that have occurred outside of nursing homes, that older people are at greater risk of death if they are infected compared to younger people.
Thank you, Rick, for that question. And thank you for that answer, Dr. LaVeist. We're going to wrap Q&A around 10:45. So I think we have time for one last question to be verbalized. And one was submitted by Rebecca Gilmer regarding, interestingly, the designation of the virus under SARS. So Rebecca, if you want to unmute yourself and vocalize your question, please feel free to do so.
Yes, guys, thank you again. You are one of the few people I hear relate this to SARS, and I am uncomfortable that that message is not getting out, and the lots of people who are deniers or just don't see this as very dangerous. So would you conjecture as to why that might be? I think that that information can help people take it more seriously. And if I may, I want to underscore something Lisa offered. She's wondering about your statistics, and it would be a help to her. I know you talk about how this comorbidity piece has been weaponized and racialized, and how white folks in the South have the same indicators, and you have some data around that. So I just want to underscore that as well as a question.
Yeah. So the SARS thing. So this virus is very similar to SARS-1. I mean, right? So that's why, in that it is a respiratory disease. I mean, a syndrome that it works very similar to that SARS virus. I think the reason that people may not be taking this as seriously as maybe they should is that we've received a lot of mixed messages from the federal government around this. And it would be, I mean, I'll go as far as to say it's like everything that we teach you not to do in health communications classes is what the federal government has done. So the president is saying, well, the president's task force says you should wear a mask. The president then says, I'm not wearing a mask, and then says many different disparaging things about wearing masks. The task force says you should be remain socially distant. And I'm using that term intentionally because I usually don't use that term, because social distancing is also a term that could not have possibly been created by someone who's been trained in public health education, because social distance is not what we need right now. We need the exact opposite. We need social connection. We need physical distance. So why we're calling it social distance, I'm not sure. But it's all part of the federal government's failure to mount a coordinated response with proper health communications techniques. And as a result, people are confused. There were early messages coming from the federal government that this was going to be like the flu. And like the flu, it would diminish in its severity during the summer months when there was more humidity and heat, and it would flare back up in the winter. Well, that pattern does not appear to be the case. This is not the flu, not by a long shot. The flu typically kills between 40 and 60 Americans, 40 and 60,000 Americans per year. COVID-19 has already killed over 120,000 Americans in just 5 months. This is not the flu, not by a long shot. And the one aspect of this that does relate to the flu is that when October comes and and influenza season comes back, you're going to have a greater need for ICU, a greater need for ventilators, because we always have a need during influenza season. And you're going to have that happening at the same time that COVID-19 is happening. And we did not, at least in Louisiana, in New Orleans, we did not ever overtop our ventilator capacity. And we didn't really have to use the field hospital that was created, that was built in the convention center very much. Things never got quite as bad as we thought it could get. But I think that this fall is very well, in winter, it very well could, when influenza season comes, and we have influenza and we have COVID at the same time, both needing to use the same hospital resources. I'll stop there, but I would also point out that we are also in hurricane season in Louisiana. So we could be facing managing hurricanes at the same time that we're managing this pandemic. So these are all the things that we're thinking a lot about and planning for down here.